right, so let's dive into primary open angle glaucoma, something you're already familiar with as an ophthalmology fellow, but we're going to go a bit beyond the textbook today, into some of the more intriguing insights about POL. But you won't necessarily find these in your typical review materials. Think of it as like a cheat sheet to some of the less obvious but super important aspects.
Yeah, like leveling up your knowledge, going from like, I know this to I really get this. And as a fellow, having that deeper understanding can make all the difference when you're making those clinical decisions.
Exactly. And, we all know the basic definition of POA.
Right.
IOP over 21,
Yeah.
optic nerve damage, visual field loss, and of course the open anterior chamber angle. But here's a clinical pearl that I think is often overlooked. POA can, or frequently presents, with asymmetric IOP.
That's right. And you may even see a significant difference in pressure between the two eyes. And that can, sometimes complicate things when you're trying to make a diagnosis. It's a good reminder that we need to be looking at the whole clinical picture, not just relying on one single number.
Yeah, it's so easy to get like tunnel vision when you're focused on a specific test result.
Yeah.
You have to zoom out and see the patient as a whole.
Yeah.
And speaking of seeing the whole picture, we can't forget about the differences in prevalence among different races. Individuals of Black African origin have a much higher risk of developing POA. So that's a really crucial factor to keep in mind when you're, assessing a new patient.
Definitely. And it highlights the importance of looking at all those different risk factors, right? Going beyond just age and family history, which are, the ones that we typically think about first.
Yeah, those are the usual suspects. But there are some other less obvious risk factors that can really kind of trip you up. For instance, did you know that even having a large optic disc can actually be a risk factor for POA?
It might seem a little counterintuitive, but those larger optic discs, they can actually be more susceptible to damage from fluctuations in IOP. You can kind of think of it like a big sail on a small boat. It's going to be more vulnerable to stress and strain compared to a smaller sail on a bigger, more stable boat. So those larger discs might be experiencing greater mechanical stress as the pressure in the eye changes, potentially contributing to that glaucomatous damage.
Okay, that's a great analogy. It really helps to visualize why those larger discs might be more vulnerable. And what about myopia? I mean, we see it all the time, but I never really thought about it as a risk factor for POD.
Well, think about the anatomy of a myopic eye. Myopia is often associated with changes in the structure of the eye, particularly the shape and the length of the eyeball. And those changes can put extra strain on the optic nerve, making it more susceptible to damage from that elevated IOP. So it's really all about understanding those subtle biomechanical factors that are at play.
So you've got those structural vulnerabilities, and then we layer on factors like diabetes mellitus, which has a possible link to long-term contraceptive pill use.
Right. There's some research suggesting that long-term use of oral contraceptives might actually interfere with a protective effect of estrogen. It's a bit of a puzzle, but it's a good reminder to really dig deep in that medical history, looking for those seemingly unrelated factors that could be contributing to a patient's risk.
It's like detective work, isn't it? Looking for those hidden clues. And then you've got vascular disease, which always seems to be lurking in the background.
Yes, vascular disease is a big one. And we're not just talking about, systemic conditions like hypertension, but also issues with blood flow within the eye itself. So that ocular perfusion. If the blood supply to that optic nerve is compromised, those nerve fibers are much more vulnerable to damage, even if the IOP isn't particularly high.
So it's not just about the pressure. It's about the health of the optic nerve and its ability to withstand that pressure.
Precisely. Now let's kind of switch gears a bit and unravel the genetic side of POA. It's a complex area, but what are some of the key things that you should know as a fellow?
Okay, bring on the genetics.
All right. Well, research has linked POA to at least 20 different spots or loci in the human genome, but there's one gene that tends to stand out, and that's MYOC. Now, this gene provides the instructions for building a protein called myocilin, which is found in the trabecular meshwork.
The trabecular meshwork, our intricate drainage system.
Yeah.
So are we saying that MYOC mutations are the root of all evil in POA?
Well, if only it were that simple. MYOC mutations are definitely present in some cases of POA, but they don't tell the whole story. It's more like one piece of a very complex puzzle, and we're still trying to figure out how all the pieces fit together. There are likely many other genes and environmental factors involved as well.
So genetics play a role, but it's not the sole culprit. Now, Let's talk about something that I think has very immediate practical implications for your practice as a fellow, steroid responsiveness.
This is such a crucial point, and it goes beyond just, knowing the concept. You need to be able to apply this knowledge in your decision-making. Think about it this way. Imagine you have a patient with uveitis who needs topical steroids, but they also have a family history of glaucoma.
Okay, I see where you're going with this. Red flag right there.
Exactly. You need to be aware that some individuals experience a significant increase in IOP when they use steroids, especially topical steroids. We call these individuals steroid responders, and they can be particularly susceptible to developing steroid-induced glaucoma.
So even if I'm treating a different condition, I still need to have glaucoma on my radar, especially when I'm using steroids.
Absolutely. Always consider that family history of glaucoma and monitor those IOP levels very closely when you're prescribing steroids, especially those topical ones. And remember, even some seemingly harmless over-the-counter medications like nasal sprays can actually contain steroids.
Yeah.
It's a good reminder to always check those ingredients and be aware of those potential interactions.
Okay, so we've talked about the risk factors, the genetics, the practical considerations of that steroid responsiveness. Now let's get down to the nitty-gritty. How does POAG actually damage the eye? What's going on at the cellular level?
At its core, POAG is all about the death of those retinal ganglion cells. Those are the neurons that transmit all that vital visual information from the eye to the brain. And it's not just any kind of cell death. It's primarily happening through apoptosis, so that's programmed cell death rather than necrosis.
Okay, so apoptosis is more of like a controlled process, right? Like the cell is kind of shutting down in an organized way, whereas necrosis is more of a chaotic explosion.
Yeah.
So why is that distinction important in POA?
Well, it tells us that the retinal ganglion cell death in POAG isn't simply due to a sudden injury or trauma. It's a more regulated process, likely triggered by very specific signals or stressors within the eye. And this kind of leads us to two main theories about how this damage occurs: direct mechanical damage and ischemic damage.
So direct mechanical damage, let me guess. That's like the pressure literally squashing those retinal nerve fibers.
You got it. That's the theory anyway. High IOP is physically compressing those retinal nerve fibers at the optic nerve head, leading to their demise.
That makes sense intuitively. But you mentioned another mechanism.
Yeah, ischemic damage. And this theory suggests that elevated IOP is actually compromising the blood flow to the optic nerve. So it's essentially starving those nerve fibers of oxygen and nutrients, and that then triggers a whole cascade of events that ultimately lead to retinal ganglion cell death.
So it's not just the pressure itself, but the knock-on effects that pressure can have on blood flow and the overall health of that optic nerve.
Exactly. And more research is pointing towards ischemic damage as a major player in POA.
Wow, that's really interesting. Makes you think about how we approach treatment and whether just focusing solely on lowering IOP is really enough. But before we get into treatment, let's talk about screening. Do we need to be checking every single patient for glaucoma?
Ideally, yes. We'd love to catch every single case early, but practically speaking, universal glaucoma screening just isn't. It's not feasible. It's not cost effective.
So who do we prioritize then for glaucoma screening?
We really focus on those who are at higher risk. So that includes anyone over 40, people with a family history of glaucoma, and individuals with certain racial backgrounds, particularly individuals of Black African origin.
And what does a good glaucoma screening involve?
It's more than just a quick IOP check. We need to be doing a thorough eye exam, including ophthalmoscopy, to evaluate that optic nerve, even in patients who aren't, coming in and complaining of any vision problems.
So it's all about catching those subtle signs early on.
Yeah.
But that brings us to kind of a tricky question. How do we diagnose POAG when the early stages often don't have any noticeable symptoms? It's like trying to find a needle in a haystack.
That's the real challenge with this disease, right? Visual symptoms often don't appear until there's already been significant damage, which is why taking a really detailed history is so important. We need to ask about family history, any previous eye problems, even seemingly unrelated systemic conditions that might affect vascular health. It's all about connecting those dots.
I've heard stories of doctors kind of finding these unexpected connections in a patient's medical history that led to a totally unrelated diagnosis. Do you have any examples like that from your experience with glaucoma?
I remember this one case where a patient came in for a routine checkup, and during the conversation, she just happened to mention that she had been diagnosed with sleep apnea a few years ago, and sleep apnea can actually disrupt blood flow, and as we've been talking about, compromised blood flow can be a factor in glaucoma.
So that seemingly unrelated bit of information kind of triggered this deeper dive into her eye health.
Exactly. It prompted me to do a more comprehensive glaucoma evaluation. And sure enough, there were some early signs of optic nerve damage. And if we hadn't delved into her medical history, we might have missed it completely.
Wow. That's a perfect illustration of why we can't underestimate the power of just a good old-fashioned history. But once we suspect POA, what are those key examination techniques that we really need to master?
Well, you'll start with the basics, of course. So visual acuity, color vision, pupillary responses. But for glaucoma, the real workhorses are the slit lamp, gonioscopy, and of course a detailed fundus exam.
Okay, let's break those down. What are we specifically looking for with the slit lamp?
We're assessing the overall health of the eye, looking for any signs of inflammation or any other abnormalities that might suggest a secondary cause of glaucoma. And we always want to get a good look at that anterior chamber angle.
Which is where gonioscopy comes in. And I've heard that there's actually a specific order to these tests.
That's right. It's really important to perform gonioscopy before pachymetry. And you'll want to note the time of day as well, because those factors can actually influence the accuracy of your measurements.
Those little details can make a big difference. And finally, the fundus examination. This is where we really get to see the optic nerve up close and personal.
Exactly. We want to be very thorough here. Always dilate the pupils to get the best possible view. And don't forget to use that red-free light. It can really enhance the visibility of those retinal nerve fiber layer defects.
It's like we're searching for clues, right? Those telltale signs of damage. and those clues can actually take on very specific patterns, right? Those characteristic visual field defects that we learn about in textbooks.
Absolutely. And understanding those patterns is key to recognizing how glaucoma is progressing. Early on, those field defects might be subtle, and they might show some variability between tests and even between the two eyes. But as the damage progresses, you start to see more characteristic patterns emerge.
Like those small paratensral depressions, which I've heard are more common in normal tension glaucoma.
Yeah.
And they can be picked up by specialized perimetry.
Yes. And then there's the nasal step, which is more likely to appear above and below the horizontal midline. And that's actually because of the way those nasal nerve fibers are arranged within the optic nerve itself.
It's all connected, isn't it? And what about the temporal wedge?
Similar to the nasal step, it indicates localized damage to those nerve fibers. Then there are the arcuate defects. So those are those arc-shaped blind spots that develop between 10 and 20 degrees from the center of your vision, and they often start as extensions from the blind spot, and then they can eventually join up, forming a ring-shaped blind spot.
It's like watching those blind spots slowly expand and merge, gradually chipping away at the patient's vision. And in the end stages, all that's left is this tiny island of central vision.
It's a sobering reminder of why early detection and treatment are so crucial, right? We want to preserve as much of that visual field as possible. And to do that, we have to think beyond just lowering IOP.
Right. It's about managing the whole patient, understanding their individual needs and their risk factors.
Absolutely. And that brings us to the question of how we actually manage this complex disease.
Okay, let's get into the nitty-gritty of treatment strategies then.
Of course. But remember, as a fellow, you're moving beyond just learning the steps. You're starting to develop that clinical judgment to decide which steps are right for which patient.
That's the art of medicine, right? Applying the science to the individual patient.
Exactly. So let's start with those three main strategies for managing POA: target pressure, proportional reduction, and response to progression. Each one kind of offers a different way of thinking about treatment, and understanding their strengths and weaknesses is key to making those informed decisions for your patients.
Okay, so let's break it down, starting with target pressure. This one seems pretty straightforward. You set a goal IOP and then you try to get your patient there.
And in theory, yes. But in practice, figuring out that target pressure is anything but straightforward. It's not a one-size-fits-all approach. We have to consider the severity of the disease, how quickly it's progressing, the patient's overall health, and their life expectancy.
So it's highly individualized, taking into account all those factors we've been talking about. But how do you actually land on that specific number? Is there like a magic formula?
I wish there were. We use our clinical judgment, of course, guided by the evidence, but there's always going to be some degree of uncertainty. We might start with a target pressure based on that initial assessment, but we always have to be ready to adjust that target as we see how the patient responds and how that disease progresses.
So it's a dynamic process, constantly reevaluating and adjusting as needed. Now, what about the second strategy, the proportional reduction? What's the thinking behind this approach?
Well, it's based on the idea that aiming for a certain percentage reduction in IOP might be more beneficial than just shooting for a specific number. So, for example, you might decide to aim for a 30% reduction in IOP, no matter what the patient's starting pressure is.
So if a patient's IOP is, say, 30, you'd aim for an IOP of 21. But if their starting IOP is 20, you'd aim for 14. Okay, I see the logic there. But does this strategy always work in practice? Are there any situations where it kind of falls short?
There is some evidence to support it, but like everything in medicine, it has its limitations. For example, if a patient has, advanced damage, they might need a more aggressive approach, even if that means going beyond that 30% reduction. It's all about balancing those potential benefits with the potential risks.
Which brings us to that third strategy, the one that really makes you think, response to progression. This one seems a bit more complex.
It is, because it forces us to confront a difficult reality. Every ganglion cell that we lose has an increasing impact on the patient's vision. As the disease progresses, the stakes get higher.
So we need to be more aggressive in our management to try to prevent further damage. But how do we actually put this strategy into practice? What does it look like in the clinic?
It's about being proactive. We need to monitor the patient's visual field very closely, carefully examine that optic nerve, and track those IOP readings over time, looking for any signs that things are getting worse. And if we do see signs of progression, we need to adjust that treatment plan, even if that means moving to more intensive therapies.
Okay, that makes sense. It's like we're always one step ahead, anticipating the disease's next move. So we've got these three strategies, each with a different perspective. Do you pick one and stick with it, or do you use them together in some way?
It often ends up being a combination, adapting our approach to each individual patient. We might start with a target pressure in mind, then shift to a proportional reduction strategy if the disease starts progressing, all while remembering that, responding to signs of progression is that ultimate goal.
It's like having a toolbox with different tools for different situations. And knowing which tool to use at which time is really what sets a good ophthalmologist apart.
Exactly. It's all about using your clinical judgment, weighing the evidence, and factoring in the individual needs and preferences of each patient. It's a very personalized approach.
Now, speaking of individual needs, let's talk about those treatment options. So medical therapy, laser, and surgery. As a fellow, you're learning the ins and outs of each approach. But what are some of those real-world tips that you're picking up along the way, those things that they don't always tell you in textbooks?
When it comes to medical therapy, one of the biggest challenges is actually just making sure that patients are using their drops correctly. I'm sure you've encountered this already in the clinic.
Oh, absolutely. I call it the case of the missing eye drops.
Yeah.
You just know that they're not using them as prescribed, but it can be so tricky to figure out why.
It's a classic scenario. So you have to go beyond just writing that prescription, right? You need to spend time teaching them how to instill those drops correctly, emphasizing how important it is to use them consistently, and really be on the lookout for those subtle signs of non-compliance. Sometimes it's a matter of education or even just problem solving, not just assuming that the patient is being difficult.
It's about being a good detective.
Right.
Figuring out what the real issue is and then addressing it head on. Now, what about when medical therapy just isn't cutting it? When do you start thinking about laser therapy or even surgery?
Well, that's a big decision, and there's no easy answer. We have to consider things like the stage of the disease, how quickly it's progressing, the patient's overall health, and of course their preferences and comfort level with different procedures.
So it's a shared decision-making process involving the patient every step of the way. We're in this together.
Absolutely. We educate them about the risks and benefits of each option, and ultimately the decision should be made collaboratively. Now, we briefly mentioned SLT earlier. What makes it such a good option for many patients? Well, for one, it's a relatively quick and painless procedure. It can be done right there in the office. There's very little downtime. And the results can be quite good, often comparable to what you would achieve with medication alone.
So it's a good option for those who are having trouble with drops or who aren't good candidates for surgery. What about those cases where SLT just isn't enough or the patient isn't a good candidate for laser therapy? When do we start thinking about surgery?
Surgery is often viewed as a last resort, but it can be a very effective way to control IOP and preserve vision, especially in those more advanced cases. The good news is that there have been some really exciting developments in surgical techniques for glaucoma.
Okay, tell me more about that. What are some of the advancements that you're most excited about?
Well, the evolution of glaucoma drainage devices has been a real game changer. These devices are much safer and more effective than they used to be, and they're becoming an increasingly popular option for patients with advanced glaucoma or those who haven't responded well to other treatments.
It's like we have this whole spectrum of treatment options now, from simple drops to cutting-edge surgical techniques.
And as a fellow, you're learning not just what those options are, but how to use them strategically and tailor them to each individual patient. It's a fascinating and challenging journey.
It is, and we're not done yet. We've covered a lot of ground today, but there's still more to explore.
Right. We've got some hidden gems to uncover. Those clinical pearls that might not be in the textbooks, but are really essential for mastering the art of glaucoma management.
We'll be back soon with even more insights and practical advice to help you navigate the complexities of POAG. Until then, keep those minds sharp. And remember, every patient interaction is a chance to learn and grow.
Welcome back. It's like we've opened up this toolbox of knowledge about POA, and now we're really going to get into, how to use those tools in practice.
Yeah, it's one thing to know the theory, but applying it in the real world, where patients don't always fit neatly into those textbook cases, that's where the real learning happens, right? Especially as a fellow, you're starting to, make those judgment calls kind of on your own.
You're absolutely right. It's all about bridging that gap between, textbook knowledge and real-world clinical practice. So let's revisit those three main management strategies that we talked about earlier: target pressure, proportional reduction, and response to progression. Remember, each one kind of gives us a different lens through which to view treatment, and knowing when to use each approach is really key.
Okay, so let's start with target pressure. I'm still a bit fuzzy on how to actually set that target. Is there a specific formula or a guideline that we can follow?
I wish there were a simple formula. Unfortunately, it's not that easy. We really have to use our clinical judgment, taking into account the severity of the disease, how quickly it's progressing, the patient's overall health, and their life expectancy. It's a very individualized approach.
So if I have two patients with the same IOP, but one is, let's say, a healthy 40-year-old,
right, and
the other is an 80-year-old with multiple health issues, I might set different target pressures for them.
Exactly. For the younger, healthier patient, you might aim for a more aggressive target pressure. You're really trying to preserve their vision for as long as possible. But for that older patient with other health concerns, a more conservative approach might be more appropriate. It's all about balancing the benefits of lowering IOP with the potential risks and burdens of treatment.
That makes sense. It's about seeing the whole patient, not just the numbers on a chart.
Yeah.
Now, what about the proportional reduction strategy? How does that differ from target pressure?
Well, with proportional reduction, we shift our focus from a specific IOP number to a percentage reduction. So you might decide that you want to lower your patient's IOP by, let's say, 30%. Regardless of what their starting IOP is.
So if a patient comes in with an IOP of 30, you'd aim for an IOP of 21. But if their starting IOP is 20, you'd aim for 14. Okay. I see the logic there. But does this approach work for every patient?
There is some evidence to support it, but like all treatment strategies, it has its limitations. For example, a patient with advanced glaucoma might need a much more aggressive approach, even if it means going beyond that that 30% reduction.
So it's not a rigid rule, more of a guiding principle.
Exactly. It's another tool in your toolbox, and you have to decide when it's the right tool for the job. Now, let's talk about response to progression, which can be a bit more challenging to kind of wrap your head around.
Yeah, this one seems less about a specific number and more about a mindset, a way of approaching treatment.
You've hit the nail on the head. Response to progression is all about recognizing that as glaucoma progresses, the stakes get higher, right? Every ganglion cell we lose has an increasing impact on the patient's vision.
So we need to be even more vigilant in our monitoring and be ready to adjust our treatment plan if we see any signs that the disease is worsening.
Exactly. It's about being proactive, not reactive. We monitor the visual field very carefully, keep a close eye on those optic nerve changes, and we track those IOP trends over time. And if we see signs of progression, we don't hesitate to adjust the treatment plan, even if that means stepping up to more aggressive therapy.
It's almost like a chess game,
Yeah.
Trying to anticipate the disease's next move. So how do these three strategies work together in real-world clinical practice?
Well, it often ends up being a combination. Tailoring our approach to each individual patient, we might start with a target pressure in mind, then shift to a proportional reduction strategy if the disease progresses, all while kind of keeping response to progression as our guiding principle.
Like you're constantly assessing, reevaluating, and adjusting your approach based on how the patient's responding and how the disease is behaving.
Yeah.
It sounds like there's a lot of clinical judgment involved.
Absolutely. Managing glaucoma isn't just about following a set algorithm. It's about understanding the nuances of the disease and using all of the tools at your disposal to really achieve the best possible outcome for each individual patient. It's a very personalized approach.
Now let's talk about those tools, those specific treatments that we can use to fight glaucoma. So medical therapy, laser therapy, and surgery. As a fellow, you're learning all the intricacies of each approach. But what are some of those practical tips you're picking up along the way? Those things that they don't necessarily teach you in textbooks.
When it comes to medical therapy, one of the biggest challenges is really just ensuring that patients are actually using their drops correctly. I know you've seen this already in the clinic.
Oh, definitely. I've had patients who swear that they're using their drops religiously, but their IOP tells a very different story. It's like a detective novel, trying to figure out what's really going on.
Exactly. And sometimes it's a matter of the patient just not understanding how to instill the drops properly. Other times it's, could be the cost of medications, or maybe there's side effects that they're not mentioning.
So we need to be really proactive in educating our patients and making sure that they understand how to use their medications correctly, and that they feel comfortable coming to us with any concerns or difficulties they're having.
Absolutely. It's a partnership, and communication is key. Now, what about those cases where medical therapy just isn't enough? When do we start considering laser therapy or surgery?
Well, I know from my training that SLT, selective laser trabeculoplasty, is a good option for some patients. What are your thoughts on SLT?
SLT has become increasingly popular as a first-line treatment for POA. It's a relatively quick and painless procedure that can be done right there in the office with minimal downtime for the patient.
Yeah, it seems like a good option for patients who are struggling with drops or who have concerns about the long-term use of medications.
Right. And the results can be quite impressive, often comparable to what we achieve with medications. Of course, not everyone is a good candidate for SLT, but it's definitely a valuable tool to have in your arsenal.
What about those cases where SLT just isn't appropriate, or it doesn't provide adequate IOP control? When do we start thinking about surgery?
Surgery is often viewed as a last resort, but it can be very effective in controlling IOP and preventing further vision loss. The decision to recommend surgery is always made on a case-by-case basis, considering factors like the stage and severity of the glaucoma, how well the patient has responded to other treatments, and their overall health and life expectancy.
So it's another one of those judgment calls that you develop as you gain more experience.
Exactly. And it's important to remember that surgical techniques for glaucoma have evolved significantly in recent years.
Oh, that's right. You mentioned some exciting advancements in glaucoma surgery earlier. Can you tell me more about that?
Well, one of the most significant advancements has been the development of glaucoma drainage devices. These devices are much safer and more effective than those older drainage implants. And they're becoming an increasingly popular option for patients with more advanced glaucoma or those who haven't responded well to other treatments.
So even though surgery might be a last resort, it's not something to be feared.
Absolutely not. It's another tool in our toolbox, and when used appropriately, it can be a very effective way to preserve vision and improve quality of life for our patients. The key is to stay informed about the latest advancements in surgical techniques and to carefully select the best approach for each individual patient.
This has been incredibly helpful. I feel like I'm starting to see the bigger picture of glaucoma management. We've talked about the different strategies, the treatment options, the importance of individualizing care. What else do I need to know to really master this field?
Well, there are a few more pearls of wisdom that might not be in the textbooks, but are really essential for any aspiring glaucoma specialist. They're more about the art of medicine than the science.
That sounds intriguing. I'm all ears.
Well, we'll dive into those in the final part of our deep dive. Stay tuned.
All right, so we're back for the final part of our deep dive into POAG. You mentioned some pearls of wisdom that aren't usually found in textbooks. What are these secrets of the glaucoma masters?
Well, they're not really secrets, but they're those insights that you gain from experience, from really observing your patients and learning what works and what doesn't. Those little nuances that you pick up along the way.
Okay. I'm ready to absorb some of that wisdom. Give me the good stuff.
One of the most important things I've learned is the power of really listening to your patients. It sounds so simple, but it's easy to get caught up in the numbers, those IOP readings, the visual field results, and forget that there's a person behind those numbers.
Yeah, I know what you mean. You can get so focused on the disease that you forget about the human being who's living with it.
Exactly. Take the time to really understand their concerns, their fears, their goals for treatment, what matters to them, what are their priorities, because ultimately the most effective treatment plan is the one that the patient is willing and able to follow.
It's like that old saying, people don't care how much you know until they know how much you care.
I couldn't have said it better myself. Building that trust and rapport is essential for any chronic disease, but especially for something like glaucoma where treatment often requires a lifelong commitment.
Makes a lot of sense. It's a partnership, not a dictatorship, right? We're in this together with the patient.
Absolutely. And speaking of partnerships, let's talk about working with our colleagues. As a fellow, you're part of a team, and learning to collaborate effectively is so crucial.
I've already found that to be true. Just being able to bounce ideas off of other fellows or get insights from more experienced attendings, it's been so helpful. It's like having a whole network of support.
Exactly. Don't be afraid to ask questions, to seek out different perspectives, to present challenging cases and get input from others. Two heads are often better than one. And in medicine, it's often a whole team working together to really find those best solutions for our patients.
It's like that proverb, if you want to go fast, go alone. If you want to go far, go together.
I love that. And let's not forget the importance of staying up to date. Glaucoma is a rapidly evolving field. New discoveries, new treatment options are constantly emerging.
Yeah, it can be overwhelming trying to keep up with all the latest research and developments. Any tips for staying on top of things?
It's definitely a challenge, but even just setting aside a little bit of time each week, to read journals, browse those online resources, listen to podcasts like this one, it can make a big difference.
Okay, so listening to podcasts counts as professional development. I like the sound of that.
Absolutely. And don't try to read everything. Be selective. Focus on the areas that are most relevant to your practice and the types of patients that you see.
That's good advice. It's about working smarter, not harder. Right?
Mm-hmm.
So we've talked about listening to our patients, collaborating with our colleagues, and staying up to date. What other pearls of wisdom do you have to share?
Right. This one might sound a bit philosophical, but I think it's one of the most important lessons I've learned in my career. Embrace uncertainty.
Embrace uncertainty. In medicine, isn't that kind of the opposite of what we're trained to do?
It might seem counterintuitive, but hear me out. Glaucoma is a complex disease. and we don't always have all the answers. Sometimes we have to make decisions based on incomplete information or when the evidence isn't clear-cut.
I guess that's where the art of medicine comes in, right? Using our experience and judgment to make the best decision possible, even when we don't have all the answers.
Exactly, and being comfortable with that uncertainty, being able to say, I don't know, but I'm going to do my best to find out. That's what separates a good doctor from a great one.
It's about being humble, acknowledging our limitations and being open to learning and growing.
Precisely. And being willing to adapt our approach as new information emerges or as the patient's situation changes. Flexibility is key in glaucoma management.
So it's not about being perfect. It's about being adaptable, resourceful, and always putting the patient's best interests first.
You got it. And that's what makes this field so challenging and so rewarding. There's always something new to learn, new challenges to overcome, and new ways to make a difference in our patients' lives.
Well, I think you've given me a lot to think about today. I feel like I have a much better understanding of not just the science of glaucoma, but also the art of caring for these patients.
Well, it's been a pleasure sharing these insights with you. And remember, your journey as a glaucoma specialist is just beginning, and the learning never stops. Keep those clinical minds sharp, stay curious, and never be afraid to ask questions.
Well, thank you so much for joining us on this deep dive into POAG. We hope you found it insightful and helpful as you continue on your journey as an ophthalmologist. Until next time, keep learning, keep growing, and keep making a difference in the lives of your patients.